joining worldwide. Very warm welcome to the first pre-conference webinar of the Colombo Conference in Medical Education 2021. Today, we are starting the Colombo Conference in Medical Education with a very important webinar that is very relevant to the current situation. The webinar is on authenticity in teaching, simulation and non-lecture-based teaching methods. That would be very relevant to the challenges that we are facing today. I would like to invite Professor Korsara Maramel, the President of the College of Medical Educationists, to give her opening remarks. Over to you, Professor Korsara.
Thank you, Indika. Good morning. And I know there were some registrants from other countries. So as the case may be, it's good afternoon or good evening. And first of all, I'm delighted to welcome all the participants to this first pre-conference webinar that is organized by the College of Medical Educationists. And the topic is timely. It's teaching around authenticity, which is the need of the hour with social distancing, and how to enhance learning opportunities. And to do the session, we have an expert with a lot of experience, and he's a clinician, Professor Michael Wilkes, who will be introduced later by Professor Indika. But I myself have followed his trainer training programs, and I know he has a lot of experience in conducting trainer training programs in different parts of the world. So it's really a great opportunity for all of us. And I would invite all of you to participate, and looking forward to an interesting and a thought-provoking session. Thank you, Indika.
Thank you, Korsala. Now I have the great pleasure of introducing Professor Michael Wilkes, a very long-standing close friend of Sri Lanka. Professor Michael Wilkes is a global leader in health professions education with a very broad background in medicine, medical education, global health, and public health. He is an ardent believer of collaborative partnership and moving beyond the boundaries of the traditional university, and to foster collaborations in global health with the students, faculty, industry, community, and other health professions. He is a pioneer of the concept of global health and conducted many international activities in relation to promoting that concept of global health, including several workshops in Sri Lanka as well. He is an innovator and would like to think out of the box to provide solutions to the challenges. So in that case, today's workshop would be very much relevant to our context, because not only Sri Lanka, but worldwide, we are facing the challenge of how to face the challenges of new normal and restart medical education. In that case, this workshop would be very much useful for all of us. Michael has a lot of experience working worldwide in USA, in Europe, and especially Africa and Asia. And his experience related to the Sri Lankan context would be very much useful for today's discussion webinar. Without further ado, I'd like to invite Michael to start the workshop. Over to you, Michael.
Thank you, Indika. Thank you, Kosala, and thank you, Pandula, for inviting me. It's a pleasure to speak with all of you this morning. It is an opportunity for all of us to remember that we're all in the same boat. Some of us have more resources and some of us have less resources. But at the end of the day, it's really not about resources. I think I'm going to try to make the case that this is about creativity, about collaboration, and about shared partnerships with only one important goal, and that is to improve the health of our community. At the very end of the day, that's what we're going to be measured on, not on our students' scores, not on what they do on their exams, but really on whether the health of our community rises. So I have got some objectives that you can read. I won't read them to you, but I'm hoping that we can share and talk about what's happened as a result of COVID, how that's changed medical education, not only during the pandemic, but what implications it might have going forward. I don't know if outside of North America, you had any experience with a game like this, but this was my first experience with simulation. It was a toy. You had a pair of tweezers, and you had to take each of the organs out of the body without causing a beeping sound. It was perhaps the preparation for surgery or something like that. So the first question is why are we even talking about simulation? It is important for us to understand that simulation has addressed several problems. One is we have problems assessing our competence. Secondly, learners need to practice with patients. It is, one second, I'm just trying to move my screen here. Okay, learners can be focused without worries about patient care. It is one of the things that made me the most crazy when I was training as a clinician, is not only worrying about how to do a procedure well, but also do it well in front of a faculty member who was grading me, but perhaps most importantly, was I going to hurt the patient? Was I going to cause them any sort of pain? Wait a second here. There are opportunities to repeat, right? If you get something wrong in the hospital, it's really hard to go back and do it again. You know, you've already caused the patient discomfort and pain, but with simulation, you can practice, you can try again without inflicting any harm. One of the other things that those of you who are clinicians know, that when you're teaching something in the hospital, it's often hit or miss, right? If somebody comes in with community-acquired pneumonia or an acute abdomen, you can teach the students or the postgraduate trainees who are right around you, but it isn't guaranteed that everybody's going to have that opportunity. With simulation, everybody can have the opportunity to practice putting in a central line, to draw blood, to read an EKG, to talk to a patient and give them a diagnosis that the pathology report came back as cancer. It is also difficult. We all know who are clinicians that patients who have interesting findings often come in at the most inopportune times, right? They come in at 2 in the morning or 4 in the morning when there aren't a lot of people around. So simulation gives us the opportunity to manage the time and to do things when both the staff are around to observe and the students are around to learn. And lastly, we can assess a student in an ideal situation. So COVID came along. It came to us in North America, and it's come to you in Sri Lanka and Southeast Asia, and it's come to Africa. But it has changed in many fundamental ways how we teach our medical students. Many of us have not been able to have our trainees in the hospital. We've needed to rely heavily on video conferences such as this. We've needed to reduce the number of trainees when we are in the hospital so that you can't have many people around the bedside. You can only have a few. And hospital patients are populating our hospitals who all have COVID, which is important, and our duty is to take care of them. But our secondary duty is to teach our students medicine. And if everybody on the ward has got COVID, it doesn't give you much opportunity to teach around, you know, an acute abdomen or you know, fungal disease or what have you. So simulation allows us to script and to make sure that everybody gets some standard exposure. So at the end of the day, I'd like to make the argument that COVID has given us some new opportunities that we hadn't had before. So what do we mean when we use the word simulation? My guess is that many of you think of expensive, high fidelity machinery that costs hundreds and thousands and millions of rupees. But I want to make the case that we don't need to go that route. Those tools are fun. They can be very useful, but by and large, they are developed to make a profit for a company. They have a very finite life. And at the end of 2 or 3 years, there's a brand new model that comes out. There's another couple of years that the company will still support the old model, but after 5 or 6 years, they'll stop supporting that, and now it's time to buy a new model. So it's a very rapid drain downward in terms of money. So we have to look to other alternatives. Simulation, if we define it, it is the act of mimicking a real object, a real event, or a real process. It does not need to involve mannequins, but it can. But simulation can be used to teach how to do procedures. It can be used to teach how to play medicine on a team. How do you work with nurses and respiratory therapists and psychiatrists and surgeons? And how does everybody come together? The quintessential example of that is a code, a cardiac arrest, when everybody has to come together. And yes, you need to intubate the patient. And yes, you need to give them the right medicines. And yes, you need to read the EKG, but you also need to be very careful, right, in how you delegate authority, how the team functions, where people stand. Are you being respectful to everyone, et cetera? There's issues with leadership. They're very, very important. Probably the most common use that I have for simulation is in teaching around clinician-patient communication. Sometimes it's giving bad news. Sometimes it's explaining a complicated concept. Sometimes it's getting permission for someone to get surgery and getting informed consent. But you can do this in ways where the patient can play a role and can ask questions that you can't tell regular patients to do to challenge the learner. You know, we think of simulation as a clinician, a veterinarian, a doctor, a nurse, a dentist, and a patient. And that patient is often human. Sometimes the patient is a dog and the communication is with the dog's owner. But I also want to propose the idea that we can have students play the role of patients to teach teachers how to teach. So we use what we call simulated students, and we can give a faculty member a challenge to deal with a difficult learning situation, to deal with a difficult student who's not paying attention or has just made a mistake. And how do we give that student feedback? How do we change their behavior? Well, I can give you a lecture on how to do that, but boy, it's nothing compared to watching you do it with a standardized student and then giving you feedback, or having a small group of students give feedback to the learner. The last thing I'll point out is that many schools are using standardized applicants to train their admissions committee on how to interview and screen students who are applying to medical school or dental school or vet school or the like. So this idea of simulation started off with patients, and it's very important, but it has a number of other uses. It can be used to teach new skills, to assess teachers' skills, to evaluate students, to teach something and reduce the number of medical errors. I think we'll just keep going here. So the question is, how and why do we teach airline pilots? So if all of you have been on a plane and you're confident that your pilot knows how to fly a plane, you know, when everything is going well, when the sun is out, there's no bad weather, there's plenty of gas in the gas tank. But I bet that you want to know that your that your pilot on the plane knows what to do when one of the two engines stops working, or when there's wind shear against the plane, or when the tank all of a sudden runs out of fuel, or the landing gear fails to descend. or what to do when there's an unruly passenger on the plane who's causing great havoc. And so we need to come up with the situation, and the airline industry was really one of the first to do this. This is a picture of an airline flight simulation. And so you've got your two pilots sitting there in the seat. You've got a faculty member, observer, watching them. He has a computer screen, so he's watching exactly what they're doing and how long it's taking them. If you notice between the two pilots, there's a camera, so they're being recorded so that afterwards they can play it back and go through and give them feedback, and they can talk to the instructor about what they were thinking. You know, I'm quite aware that you're listening to this lecture because you're interested in teaching students to be doctors, not to be pilots. But the analogy, I think, is quite appropriate. Simulation is not something that's new. This is the hospital that I trained at. And in North America, they were one of the first to use simulation, more than 100 years ago. And I'm sure it's been used around the world even before that. In medicine, we have a tradition, at least in North America, we have the saying that goes, see one, do one, teach one. And for most of my training, that's how I got trained. I saw somebody do a lumbar puncture. Somebody watched me do a lumbar puncture. And then the third time I was teaching somebody else how to do a lumbar puncture. Well, it caused a lot of harm, right? It often led to patients having to be stuck 3 and 4 and 5 times. Sometimes it led to infections if the person didn't use proper sterile technique. And there's been a huge amount of attention around the world on medical error. Just in the United States, it's estimated that just under 100,000 people die each year from medical errors in the hospital. So we have moved from the see one, do one, teach one to the model of observe some, practice several, pass an assessment, and only then can you perform it on a real patient. So in many ways, we've had to break the tradition. What else can we teach and assess with simulation beside medical procedures? We can teach how learners develop management plans. We can assess their analytic thinking. We can see how they apply knowledge to an actual patient. We can assess communication skills, and we importantly can assess ethically sound practice. I don't know if any of you listening this morning teach ethics, but it's really hard to assess somebody on ethical principles. If you use a multiple choice test, it's always pretty obvious what the right answer is. But if you use simulation, you can have the patient do something or say something or set up a situation where the student has to choose how they're going to act in an ethically demanding manner. So it is this idea of this cycle. Many of you will know this cycle was developed by Kolb, where you experience something, you reflect on it, you conceptualize what it is you've just done and how you've done it. You decide if you're going to experiment and change things, and then you have a new experience. So if we take these 5 principles here, we engage students in a process that enhances learning. Again, lots of what we teach can't be learned in a book or by Googling an answer, right? It has to be done in real time. Students have prior beliefs and ideas, and through simulation, we can draw out those beliefs and ideas and help them form new ideas. We recognize that learning is a process which needs to cycle between reflection and action. Don't just do something, think about it, think about why you've done it, think about how you could do it better, and perhaps try it a second time. Learning happens most effectively when there are interactions between different people or people and the environment that they're going to someday work in. And I hope that you'll all agree with me that learning is much more than just rote memory. It involves reasoning, it involves feeling, it involves perceiving, and it involves behaving. And it is simulation that allows us to teach all of those things. Remember Bloom's famous taxonomy, and we're really good at the base of the triangle here. We can teach, or we think we teach students things that they have to remember. I think the secret is that we don't really teach them what they need to remember. We tell them what we're going to examine, and they learn themselves what they need to remember. But as you move up this pyramid, our job as teachers becomes far more important, because we're not just telling them facts, we're telling them and helping them understand how to apply those, how to analyze them, how to evaluate them, and how to create them. Also, just to be more theoretical here, Miller's taxonomy reminds us that we go through these sort of 4 steps, right? Where there are skills and attitudes and knowledge. On the far left, we've got cognition and we've got behavior. But at its core, students have to know something. They have to know how to do something. They have to be able to show how to do something. And then they have to actually do that something. And this, while it wasn't written about simulation, this is at its core what simulation is about. I'm going to teach you how to intubate. I'm going to teach you how to sew or suture. I'm going to teach you how to fix a molar. I'm going to teach you how to do a procedure on a dog, whatever it is. First, I'm going to teach you what you need to know. Then I'm going to I'm going to teach you how to do it. You're going to show me that you know how to do it. And then we're going to actually go to the patient's bedside. And because you've shown me in the simulation lab, we're going to be able to do it at the patient's bedside. It is important to recognize that simulation does not have to be expensive. Simulation is just one tool in a toolbox, and that toolbox has lots and lots of other tools. But it can be used for teaching lectures and labs and case discussions. It can be used in assessment simulation. It can be used as part of a multiple choice exam, where you actually have an exercise with a patient, and then you have to go and answer some questions. It can be used in an OSCE. I think you all know the concept of objective structured clinical exam. They can be used in an OSV, objective structured video exercise, where the students watch a video that gives them the background, and now they have to go have an interaction with an actor or an actress. And simulation does not need to require expensive equipment. It can, but it doesn't need to. We can use real patients. We can use other students to play patients. In our school, we use people from the community, sometimes from the university, who are actors and actresses, and sometimes people from theater companies in town that are actors and actresses. Simulation includes desktop simulation. If anybody's interested, you can write me. We have a great desktop exercise that we developed around COVID, where different groups are playing different experts. There's an epidemiologist, there's an infectious disease specialist, there's a family member, there's someone from the Ministry of Health, and they all have to solve a problem. And that is also simulation. We can use mannequins, and I'll show you in a moment, we can use virtual reality. So let's have a little poll here. Which of the following are uses of standardized patients? A, to teach students to give bad news. B, to assess teachers. C, I have to move the thing, to teach students how to take an evidence-based history. D, to teach interprofessional teamwork skills. Oh, this is the wrong poll question. But you're right there on that one. it was biochemistry is not the right place. Ten more seconds. Excellent. So I think we'll stop there, but almost all of you got it. Every one of those is right. It is all of the above. Every one of those things can be used to teach and to use simulation. I find standardized patients to be the very most useful tool. Standardized patients are when people are trained to portray specific diseases, specific emotions. Somebody's angry, you were late, you came in, you didn't address me, my wife died. They can portray those emotions. You can have somebody who have different educational levels. I don't understand what you mean, doctor. Could you explain that to me again? I don't understand that vocabulary. Or they are trained to have certain behaviors specifically for the purposes of teaching. So they're not playing themselves, they're playing a script that you write for them. And in that way, we can assess their communication and professional competencies. We can assess history taking. Again, I don't know how you do this in your surgeries, but it's really hard with a big group of students to assess how well a student takes a history. And sometimes a good student has to take a history on a patient who's not particularly cooperative. And so we're able with standardized patients to put everybody through a similar exercise and assess them on a matrix so that they get an idea how they're doing and we get an idea of where they might need some additional work. So again, we can have humans as a living model. We can, on the far right here, you see a human. We have a mannequin there. The mannequin obviously isn't saying anything, but in this case, the nurse has to have a conversation with the standardized patient, who's the wife. It also, we have in cardiac arrests and things, when we have used mannequins, we've put a small speaker that you can get for a couple of thousand rupee underneath the mannequin, and somebody is in another room speaking in a microphone, and they're playing the mannequin, so they can say, "Ow, that hurts," or "I can't breathe," or "Could you help me? I think I'm going to die. Please, please, please." So we can even be creative with very inexpensive tools. We can use moulage, which is this idea of having somebody who comes in so that they look like they've had some sort of a major injury. We can do childbirth. This is a combination, obviously a real woman, a live real woman, but she can talk to the standardized patient, can talk to the trainee as she's delivering a baby. In the middle, we can use this for terrorist activities or trauma, like a plane crash or a train crash or something like that. And lastly, we can, on the far right, combine both mannequins and live patients. It is also important this is an example. I'm just going to share with you for a wee moment. This is an exercise that we've just done. A new patient, her name is Lori, coming to a surgery after she had a dog bite. The dog's 3 years old. It lives next door, and it had 3 puppies about 4 weeks ago. Lori lives with her 14-year-old brother and her father. Her mother died 15 months ago, and following her mother's death, the past year has been really difficult for Lori. The case that the students in a small group of 8 have to discuss, 4 of the students are medical students and 4 of the students are veterinary students. And the case is designed to uncover learning around animal bites and how we deal with animal bites, the idea of rabies and how rabies is spread in both humans and animals, and how we prophylax against rabies, interprofessional, why the management of this condition is going to require both a veterinarian and a physician, and it might involve public health experts, and it might involve infectious disease experts. And then there are ethical issues around putting the dog to sleep and euthanasia. And obviously in Sri Lanka, that has different implications, being a primarily Buddhist country, but everywhere people are hesitant to put down dogs. So the question is, how might some learning objectives be included that involve simulation? So in this particular case, we had a standardized patient, Lori, and she came in, she had a dog bite. We got to look at the dog bite, and she, we had to take the dog to the lab. She was really scared. The veterinarian had to explain what they were going to do with the dog and how they were going to test it. And she kept wondering, are you going to put it to sleep? Are you going to put it to sleep? And anyways, you get the idea, but it's an example of how we can teach across professions using both standardized patients and interprofessional education. So this is, if anybody wants, you can send me an email and I'll send you the case and the script and things like that. The pros of using standardized patients is it consistently creates a clinical scenario for standardized teaching or standardized assessment. It allows the ability to teach or assess rare conditions, right? In most hospitals, you can't depend on somebody with rabies coming in every single day, so everybody gets exposed to it. But you can do that with simulation. Patients can be trained to provide feedback so that you don't need to rely on faculty and professors and lecturers. You can have standardized patients give basic feedback, and you can have all of this take place in a real setting, in a real surgery, in a real hospital bed, in the hospital, etc. Let me pick up the pace a little bit. The cons are, it does cost some time. You have to pay for and train the standardized patients. You need to train them separately. If they're going to play a role, you have to train them. And then if they're going to assess the students, they have to learn what good and bad performance is. And the quality of the performance is heavily dependent on how well you can train them. It gets pretty easy after you've done it a while. In terms of, technology, it allows us to closely mimic human tissue. We can allow for replication of actual procedures. Commonly used examples of what we might do to improvise technology is using a slab of ribs from a cow or a pig to teach around the insertion of a chest tube, using animal feet or a head to practice suturing skin, etc. Teaching around cognition is a little bit more difficult. Again, you need to have discussions with the learner about what they're thinking and why they're doing stuff. And so you can ask them to stop, to freeze. Let me ask you what you're going to do now. Why did you just ask her that question? Why did you just do what you were going to do? And before you go to do the next thing, help me to understand what's going through your mind. What are you thinking? What is your differential diagnosis at this point? So you can use this for cognition. Again, there is this looking at how you can teach around crisis. I don't know if you're familiar with the team steps. This is a program that was developed in North America to teach around healthcare leadership and quality assurance. There is this program I was talking with you about. It's called PrEP, but it's a free piece of software that allows us to create tabletop simulations that students can do. The advantage of tabletop exercises, it's your teeth. You can do them at multiple sites. They're easy to duplicate, so you can replicate them quickly. You don't need to teach faculty to do a lot of different things, and you can create models and experiences that might not otherwise be accessible. The cons are that there's perhaps less real life experience when you're doing something on a computer. It often does not duplicate the most difficult aspects of the procedure, right? You often, have a harder time simulating that on a screen, and that you're using static devices so that it's useful for specific procedures, but not in challenging clinical situations. Online simulation, again, some very cheap or free software. These are some cases that I've developed. Low cost, people can do them at home on their computer. You can assess them. They can take a quiz either before or during or after. Again, there's nobody on this call that I couldn't teach to use this software in 3 minutes, maybe 5 minutes if you're over the age of 40. But if you're under the age of 30, you probably just take a minute. So there's using technology. We've got technology for innovation and pericardiocentesis and central lines and tubes, and you've seen all of this. It is to say that there's also simulation that we use in animals, and it's not just humans, right? You can see this is from our lab. This is a simulated horse. These are simulated dogs to teach innovation. The problem with task trainers, as I mentioned earlier, they're great. They're very effective, but they're expensive. They focus on a single task, and they're usually not integrated into complete patient care. Mannequins, I think we'll go quickly here. There are low fidelity mannequins. There are medium fidelity mannequins, and there are these super high fidelity mannequins that do all kinds of things where hearts, you can change the EKG. If a patient gives a medication, there's a QR scanner, and the syringe gets scanned, and it measures how much of a dose it is, and the patient will respond. So if you're giving epinephrine, the pressure will go up and the pulse will increase, et cetera, even though it's really just liquid water. It's all programmed. So you can get very sophisticated. The pros are that it's very immersive, it's very real. The cons are cost, and the first con is cost, and the second con is cost, and the third con is cost. Virtual reality, it is something that's being used a bit here in North America. It's incredibly expensive. It is incredibly cool. And you wear these headpieces, and it is, I can't tell you how exciting it is. I don't know how effective it is at teaching, how you can go from this method to actual patients, but it's coming. And if it's not ready for prime time, I want to remind you that, most of our hospitals now have robotic robots in the operating room, and they all have simulations as well. But coming to the close here, what is the evidence that this works? You guys are teachers. I've told you that there's a lot of tradition in how we teach, but there actually is a wealth of data that simulation works. There will be a couple of articles posted in chat that you can look at. You can certainly do a Google chat, but there's growing evidence that simulation improves healthcare, it reduces error, it improves professionalism, and it improves teamwork. All of those, not with one study, but with many studies that have shown that. The other thing to mention, I know that many of you are under pressure from your department or your faculty to do research. And just to remind you that there are huge opportunities for research around using simulation, to compare traditional approaches to simulated approaches, to look at outcomes that vary from patient satisfaction to procedures and how well they're done, et cetera. Lots of books that you can look at that deal with simulation and standardized patients. Again, my last slide here is a reminder that how do we teach with simulation? We have to design a simulation that provokes the students. We need to develop milestones or outcomes that we want to teach. We need to train the teachers. We need to train the standardized patients if we're going to use standardized patients. We need to be able to record or observe the performance. We need a metric that tells us what a poor performance is, what an okay performance is, and what an outstanding performance is. And that should be very clear, both to all the faculty and to the learners. And then afterwards, we have this opportunity to debrief and reflect. We want to provide feedback after the experience. We want to give them an opportunity to practice again. Again, this isn't pass and fail. If they haven't performed up to competency, they need some help, some skill building, and they need to, again, try it a second time. And perhaps with a different standardized patient or in a different context. Lots of theory behind what we're doing, lots of taxonomies, lots of different ways that we can approach this. I think I'll stop there. I'm tried to leave about 20 minutes here for questions, and I'm at your service. I'm happy to hear if you disagree with me. If you'd like to hear more on something, please ask, but I'm going to leave it to the moderators to perhaps look at the chat and see what you guys want to hear more about. But I thank you for your attention. My goal was to challenge you, to let you know that simulation is not something that you have to be afraid of, whether you're teaching in the foundational sciences or the clinical years or the postgraduate years, whether you're teaching health science students or you're teaching teachers to teach. All of this, simulation is your friend and can enable you to do a much better job.
Thank you very much, Michael, for that fascinating presentation, and also been really out of the box with providing so many options within the toolbox. Maybe I'll start with a question, the discussion, with a question that could be in the minds of most of us. I can see a lot of senior medical educators and administrators and even deans among this audience. And maybe one question that is playing in all of our mind is, what would be the role of simulation in addressing our current challenges? For example, in the new normal, we are struggling to get back and restart medical education. And you are very much aware of the Sri Lankan setting and the context where in the tertiary care hospitals, the equivalent to the US academic medical centers, where a large number of students are present in the final year and the clinical training. So how can we address, based on the current travel restrictions, mobility restrictions, and then the number of gatherings of students has to be limited. At the same time, Sri Lanka and South Asian countries may not be with the highest technology that is available, or even the financial resources. So how can we face this challenge, and what would be the role of simulation in facing this challenge of moving into new normal? Over to you, Michael.
Yeah, thank you, Indika. I think that simulation is the only approach to get you out of the bind that you're in. And it isn't a Sri Lanka dilemma. It really is a global dilemma. I think educators all over the world are facing some of the challenges that you're talking about. And just by way of example, if we look at the fifth or the sixth year of medical school, your students are being required to learn about core pediatric cases and core internal medicine cases, and in animal health, core surgical cases, et cetera. And as you say, you're not able to bring all the students into the hospital at once, and you're not able to give them all a similar experience because the hospital are so filled with COVID patients. So one of the things that you could do is you can create a small group simulations with patients where they either watch a video or they deal with an actor or actress who comes in with a presenting symptom. Those can be, I wouldn't use small children, but they can be young adults, 12, 13, 14-year-olds, all the way up to elderly people who come in and can cooperate and help you. One of the things that we found very, very useful is to use many of our retired medical faculty who are older and still want to contribute, but make absolutely wonderful faculty. The only problem there is you have to convince them that their job is to play a role and not to teach. We don't want them lecturing the students. That has been a problem. The second thing is you can create online cases. Let's say in internal medicine, which is my background, there are a number of cases that we might want to have them understand someone with thyroid disease, or someone with an adrenal disease, or someone with infectious disease, and someone with cancer, et cetera. And so we can create online cases where we have the patients speaking to the students. They have to go through, the faculty member can give a brief lecture after the patient speaks or before the patient speaks. And now they have to choose to answer a number of questions. And, sort of in that simulated model, they've got these cases that they're working through, so that by the time they do get a chance to go to the hospital, they will have had a chance to develop some of the cognitive processes that go along with the workup of someone who presents with a breast mass or with a bright red blood from the rectum or the like. And then lastly, if we take suturing as an example, it is probably not a surprise to your surgeons. Many of them have learned to suture on animal feet and the like. And, that can be carried on, and they can learn to do that much more effectively, have more time to do that before they get to the hospital. So there's not a one size fits all, but we've been able to teach. Our students weren't in the hospital for an entire year. And we didn't hold everybody back. The classes kept going. They were online. They were through simulated exercises online. They were through videos, etc. Our students have come back recently, a couple of months ago, and it looks like they're not terribly far behind. We've been able to keep them up, and they're a little bit rough around the edges, but nothing compared to if we had let them go for a year and had to start from scratch.
Thank you, Michael. And maybe I'll ask another question that's again based on several comments that are coming from the chat also. A question that is linked to your previous answer. Now, you have described many innovative methods like online simulation and maybe the moulage, and perhaps, even more sophisticated like virtual reality, gamification, so on and so forth. So all these are very exciting. Now, how can we get them into one coherent program, one standalone coherent program to achieve the outcomes of the actual clinical training? If we are to move towards incorporating simulation in a meaningful way, using those different options and even different settings, like moving away from the traditional academic medical center or the tertiary care setting and getting the involvement of other stakeholders, team-based learning, collaborative learning, and using different settings for clinical teaching, and incorporating these different options in a meaningful way so that we achieve the objectives of clinical training, especially in this new normal. This perhaps would need a complete new way of thinking and moving away from the traditional mindset. So how can we address the challenge of traditional mindset of clinical teaching? Why I'm asking this question again is I see many senior medical teachers in this audience, so that would be very much. We are really looking at a complete new way of thinking, how to do business. So what's your answer? Thank you.
Well, it's a very challenging question. I think that my immediate answer is that if any of you who are on this call want to spend additional time thinking about this. I'm happy to meet with you again, for an hour or an hour several times. I'm also happy to, if several of you from gynecology or from pediatrics want to think about how you can use simulation, I'd be happy to meet with you as well in a group over Zoom. I think the broader answer, Indika, to your question is that everything needs to be tied, I think, to competencies and milestones. Remember, competencies are what you have your students, the level that they have to achieve to get a degree, an MBBS or what have you. Milestones are marks along the way that they have to meet. And so let's just take at the end of year 4 in the medical school, in a pediatric rotation, the pediatric department needs to decide what are the milestones that they want to teach? What are the things that at the end of their course, the students should know, the students should behave, the students should be able to do in terms of skills, etc. And once they get those, some of those might lend themselves better to lectures. And the question is, do you want to do them in a traditional lecture format, or do you want to do them online so students can interact? And I like now chunking things into 10 or 15-minute segments online, and then giving them some assessment questions, and then doing the next 15 minutes rather than a full hour where they get sort of dizzy and they can't absorb everything. So once you develop the competencies, you develop the milestones, then I think as I don't know if you can see, but I've got a lot of white hair, and I had, was set in my ways for a long time, but I think that there's nothing in my entire career that's been more fun than working interprofessionally or across schools to develop teaching cases. There's no reason that Colombo has to have its own pediatric cases and Paradinia has to have a separate set of pediatric cases. Unless I'm mistaken, my guess is that pediatric disease is the same in Candie as it is in Colombo, and it's the same as it is in Gaul, et cetera. So perhaps, some of these special interest groups can come together and develop cases. Each school can put their own twist on it. The other thing that has happened here in the state of California, we have, I think, 13 medical schools in the state, and we've developed our own assessment exercise. So final year students go through the exact same 7 stations wherever they are, using the same roles, different actresses sometimes, although sometimes we're using the same actresses for fidelity, but it allows school A to look at how their students are doing compared to the other schools. So we can get norms and we can get averages, we can look at procedures, we can look at history taking, and then between each of these stations, we have intersession exercises, so that, again, it might be an opportunity for Sri Lanka to work collaboratively across the medical schools to develop a toolbox or a database of cases that people can take and modify as they see fit, but at least there'll be cases that will have the curriculum, they'll have the student handouts that they'll need, they'll have the standardized patient scripts, et cetera. So there are ways to do this. And again, it may seem to you overwhelming, but it really isn't. It's very, very enjoyable. And at least for me, working with colleagues is the best. And the other thing I should say before I close this, Indika, is the other trick that I have is that I have all of our final year medical students have to work on a case. So they have to work on the case with a faculty member. So that's a way that we've been able to generate a lot of cases, is that they take a case for the second year, the third year, the fourth year, they go to a faculty member in orthopedic surgery or ENT or ophthalmology or pediatrics. And there's a whole template that I've developed that I'm happy to share with any of you on how you develop these cases. And then the faculty member has to sign off at 4 different times in the development. And then the case gets peer reviewed by people outside of the people that developed it. So your final year students, remember, or maybe you've never heard this before, but I'm a firm believer in the fact that you never, ever know something as well as if you have to teach it to somebody else. So if you're taking your fourth year students and saying, I want you to develop a case on rabies or on the acute abdomen or on otitis media or what have you, they have to do all the background reading. They have to get to be mini experts on that topic. And then they know much better than I do developmentally where a second or third or fourth year student is and what they want to know. So they can make it even more exciting than I can by myself. Does that make sense?
Thank you, Michael. So you highlighted the need for systematic, deliberate planning of educational design, the importance of educational design. And also very importantly, you highlighted the need for the collaborative partnership, because the collaboration will make it doable, overcoming this massive challenge. I suppose the College of Medical Education is under Professor Kosala's leadership, can play a major role in forming this collaboration with different medical schools in Sri Lanka, and maybe with the region also, with other associations like CRAMI and WHO, so on and so forth. And good news is this workshop is not just an end in itself. Michael has very kindly agreed to support us right throughout, and this conference will be leading to the Colombo Conference in Medical Education. And during the time period, what we have planned is to think of a series of projects that would be planned by you, the participants of this workshop, and you can come up with your proposals, and we'll be forming a platform to work on these proposals and maybe to implement them during the next coming period, and how to address the challenges that we are facing right now. And Michael has very kindly agreed to support us in implementing them. So that would be a very good news for all of us. Michael, before we conclude, any concluding remarks? Not that we are going to conclude the project that's going to be a long term, but for this webinar, any final message that we want to give to all our participants?
No, I was just going to quickly put here in the chat, if everyone can see this. This is my email address, and if you have got specific questions, please let me know. I maybe didn't do as good a job as emphasizing that not only is there the opportunity to build teams and collaborations across the medical schools in Sri Lanka, but nursing is doing the same thing, and the veterinary school is doing the same thing, and dentistry, and I just would encourage you to think about how you can collaborate across the health professions. Maybe not all the time, but for some important cases where you're teaching around teamwork and collaboration, etc. Anyways, if anybody wants to meet again, I'll leave it to Kosala and to Indika and Pandula to sort of put together something, but I'm at your service, and I wish you luck, and it will be fun. If you take this on and try it, it's going to be enormously rewarding. If for no other reason, your students will love it. It feels very genuine to them, and it takes them away from memorization and puts them closer to the reality of practicing medicine or nursing or veterinary medicine. So thank you all for your attention. I really appreciate you spending this time this morning with me, and thanks to the leadership for inviting me. It was an honor to be with you.
Thank you, Michael, for that very insightful start, and we are looking forward to collaborate and to a fruitful collaboration. I'm sure it's going to be very, very much a kind of model for the region, and maybe a model for the world as well. And with that, we come to the end of this very fascinating and insightful webinar. I would like to invite Dr. Sisir Dharmaratna, who is the chairperson of the Colombo Conference 2021, to provide a word of thanks and his concluding remarks. Over to you, Sisir.
Thank you, Professor Indika. It is indeed a privilege to come at the end of a very successful webinar to say a few words of appreciation. As a chairperson of the organizing committee of the Colombo Conference 2021, let me first thank Professor Michael Wilkes for the well thought through presentation and very resourceful discussion on simulation and non-lecture based learning. Proving his passion for collaboration, he has already offered an opportunity to continue to engage with him in developing projects within your own institutions that would enhance the student experience through simulation and knowledge-based learning and teaching. The Colombo Conference 2021 will facilitate this continued engagement through developing and maintaining a suitable digital platform. I will brief on this a little while. Let me also thank all the colleagues who joined us from around the globe to be part of Colombo Conference 2021. It is heartening to see your enthusiasm in medical education and your commitment to help your learners to transcend boundaries of healthcare. Let me also thank our team, Professor Indika Karunatilaka for moderating the discussion, and Dr. Pandula Siribaddana, Dr. Chamika Sinanayaka, and Dr. Rizka Ishan for background coordination, technology, and secretarial support. I have 4 brief announcements to be made. 1, to facilitate the continued engagement with Professor Michael on projects that are relevant to your own institutions, we have already shared a link for Google Form to express your interest. We will also email you the link so that you can start the ball rolling. Number 2, you can expect more exciting pre-conference webinars along some exciting themes. I invite you all to visit the conference website www.colombocme.org for further details of these webinars. Our main conference will be held on 18th and 19th of November 2021, and we'll have 2 tracks of registration, one for total virtual participants and one for the face-to-face participation. Some of the sessions of the conference will be delivered in hybrid fashion, linking both virtual and face-to-face participants. So, needless to say that we are looking forward to an exciting intellectual experience that has never been possible before the COVID-19 pandemic. You will be informed once the registration for the main conference is open. Lastly, the deadline for abstract submission falls on the 30th of this month. Both oral and poster presenters will get an opportunity to present their work online with wider dissemination through online platforms used by the conference. This will be an invaluable opportunity to reach audiences that you have never been able to reach before. We invite you all to make the best use of this opportunity. So with that, let me conclude the first ever pre-conference international webinar of the Colombo Conference on Medical Education 2021. Look forward to meet you all virtually at the next webinar on the 15th July 2021 at 11 a.m. Colombo time. Till then, goodbye and stay safe. Over to you, Professor Indika.
Thank you very much. Thank you, everyone. Michael, Kosala, Sisira, Pandula, Rizka, and the team. With that, we come to the end of this workshop, but this will not be the end of this activity. We'll be contacting you very soon related to the first with the video. We'll be sharing the video with Michael's kind consent with all of you and others as well, because our idea is dissemination of knowledge and information. And then we'll be starting the projects that are related with the participation of all of you. And thank you very much and have a great day. Thank you.
Thank you.